Okay, so good morning, everyone. Just going to get things started. My name is Joshua Van Rye. I'm a Research Services Officer in the OVPRI at UTSC. I'm here with my colleague from the OVPRI, Anika Nifsud. So just want to ensure that everyone has the opportunity to participate and to perceive all that is presented today. Should you need to turn on the live captions, please go to your meeting controls under more actions. And you can turn on or off live captioning. I'm going to turn off my video now to ensure a good connection for everyone. So just a reminder that this webinar is being recorded. To please mute your audio and turn off your video to accommodate those who do not have enough bandwidth. We will be hosting the recording on the UTSC Research YouTube channel, as well as the OVPRI website at a future date. This information will be put into a chat box at the end of the Q&A, and it will also be emailed out to everybody who registered for this event. So we also ask that participants hold questions until the end of the talk, and if you do have any questions, please put them in the chat box. So with that, I'm going to turn things over to Professor Irina Creed.
Thank you so much. And before we begin, I would like to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and I am grateful to have the opportunity to work on this land. The Celebration of Research Excellence lecture series is sponsored by the Office of the Vice Principal, Research and Innovation, and celebrates those who have won awards from our office, the Principal's Research Award, recipients of Canada Research Chairs, as well as recipients of honors from the Royal Society of Canada. And today we are celebrating Professor Hilary Brown. Dr. Brown is an assistant professor in the Department of Health and Society at UT Scarborough and the Dalai Lama School of Public Health. And she is cross-appointed to the Faculty of Medicine's Department of Psychiatry. She holds a Canada Research Chair in Disability and Reproductive Health, and her research examines maternal and child health in populations with disabilities. She was the principal investigator of a U.S. National Institutes of Health grant using Ontario-wide health records data to study pregnancy in women with disabilities, the first study of its kind in Canada and one of the largest worldwide. Her work resulted in Canadian consensus guidelines for the primary care of adults with developmental disabilities, which included, for the first time, prenatal care recommendations for this marginalized population. Her work is also being used to create childbirth support tools for women with developmental disabilities. Professor Brown's research excellence has gained recognition from experts and the media with interviews in the Globe and Mail and the New York Times, among others. We are thrilled to have you here today, Professor Brown, and it is my privilege to pass the mic over to you so we can listen to your presentation.
Thank you very much for the kind introduction. So I'll share my slides, always the trickiest part. Here we go. There we go. All right, so thank you very much for the opportunity to speak today. It's a real pleasure to be able to reflect on some of the work we've been doing around improving accessibility of reproductive health care for women with disabilities. And I'll be presenting some results from a multi-method study that we have been conducting over the last 4 or 5 years. I'll start by giving some context to this issue, and then I'll present some findings related to population-based research as well as a qualitative study, and I'll finish off by providing some recommendations for improved clinical care. I want to start off by acknowledging the many people that have been involved in this research. This is work funded by the U.S. National Institutes of Health and the Canada Research Chairs program. And it's a collaboration across my team at U of T, as well as researchers at the Hospital for Sick Children, Unity Health Toronto, Women's College Hospital, Ohio State University, and Virginia Commonwealth University. And we also work very closely with a large advisory committee comprised of people with lived experience of disability, social and health related organizations in our community, as well as clinical care providers and representatives from the Ontario Ministries of Health and Children, Community and Social Services. We also have a wonderful group of grad students and postdocs who have contributed to this work, and a fantastic study team as well. So you get to see their smiling faces on this screen. So just by way of a little bit of context, between 12 and 15% of reproductive aged women have a physical, hearing, vision, or developmental disability. So that's quite a large proportion of the reproductive aged population. In 2005, the World Health Organization released a landmark report calling for better reproductive health care for women with disabilities. And yet, over 15 years later, women with disabilities continue to report being overlooked and underserved in reproductive health care settings. So when we think about why this might be, I think it's really important to consider and reflect on the long history of institutional segregation and sterilization that we have in Canada. Through much of the 20th century, people with disabilities were subjected to mass institutionalization. This was particularly true for individuals with intellectual and developmental disabilities, but also occurred quite often for those with so-called severe physical disabilities as well as sensory disabilities. But what many of you may not realize is that this history of institutionalization is actually not so far in the past. And in fact, the most recent institution for people with intellectual and developmental disabilities didn't actually close until 2009. So that was not that long ago. It's also important to recognize the long history of sterilization in our country. Until the 1970s, many provinces had involuntary sterilization laws that allowed sterilization of people with disabilities and other groups without consent. And this was a practice that was supported by the Canadian Medical Association. So again, it's extremely important to keep this historical context in mind when thinking about present-day reproductive health care for people with disabilities, because this history still does impact their healthcare experiences. So when we started doing this work, I'm a perinatal epidemiologist by training, and so most of my research is published in obstetric journals. And when we first started doing this work, we got a lot of resistance from obstetric journals asking, how is reproductive health in people with disabilities relevant to obstetricians? Because there's this assumption that pregnancy was not that common in people with disabilities. And so one of the first papers that we did in this area was trying to actually document the frequency of pregnancy in people with disabilities to counteract some of those assumptions. And so what you see here is rates of pregnancy in people with disabilities compared to those without disabilities. In these figures, the vertical bar with the one beneath it indicates no difference between people with and without disabilities, where any data to the left of that line indicate lower rates of pregnancy rates. And what you'll see is that there really are very small differences in pregnancy rates in people with physical and sensory disabilities compared to those without disabilities. And if you look at the numbers, the absolute difference is not that large at all. Rates of pregnancy in people with intellectual and developmental disabilities, as well as those with multiple disabilities, are somewhat lower, but indeed these data show that pregnancy is not uncommon in these groups either. And then if we look at pregnancy rates according to 5-year age group, in fact, when we look at the youngest population, 15 to 19-year-olds, pregnancy rates are actually higher in those with physical, sensory, and intellectual or developmental disabilities compared to those without disabilities. Looking at this from a longitudinal point of view, we know that fertility rates in Canada and in Ontario specifically have decreased over time. And you'll see that in the bolded black line at the top of this figure, a slight decline in fertility rates between 2003 and 2017 in those without disabilities. But what we see happening at the same time is increasing pregnancy rates in those with sensory disabilities, as well as multiple disabilities. And so, this is suggesting that any gap in pregnancy rates between those with and without disabilities is potentially closing. And I think the most important statistic that we saw from this work is that if we take all these data together, what we see is that 1 in every 8 pregnancies in Ontario are to an individual with a physical, sensory, or intellectual or developmental disability. And therefore, this is relevant to obstetricians and other reproductive healthcare providers. So I want to also think a little bit about existing social and health inequities that people with disabilities experience. This is really important context for understanding why we might want to pay close attention to reproductive healthcare and reproductive health outcomes in this population. And there's a huge body of literature from outside of this, outside of pregnancy-related research, but in the general disability literature, showing that there are a number of social and health disparities that people with disabilities experience. People with disabilities in childhood are less likely than their peers to receive access to sexual health education. They're more likely to experience major barriers to education as well as employment. They're more likely than their peers to experience unstable housing and food insecurity, as well as lower overall family income compared to those without disabilities. Women with disabilities in particular are more likely to experience isolation as well as intimate partner violence and assault. And even in our universal healthcare system in Canada, there are important gaps in access to healthcare services, from physical barriers to care to attitudinal barriers to care. And this plays out in lower rates of access to preventive healthcare and other healthcare services in people with disabilities compared to those without. And then finally, it's important to acknowledge the widespread experiences of ableism at a community level that people with disabilities experience. Now, the reason why I want to highlight all of these factors is that each of these social and health factors are known predictors of reproductive health disparities. And so if we know that people with disabilities are already experiencing these social and health inequities, it would not be surprising if these had an impact on their reproductive health outcomes. There have been a few previous studies looking at pregnancy outcomes and healthcare experiences of people with disabilities. Most of this research has been from the US, with a little bit of work in the United Kingdom and Australia as well. And together what this research shows is that women with disabilities are more likely than their peers to experience higher rates of gestational diabetes, gestational hypertension, cesarean section, and preterm birth. All of these are complications that are addressable through better access to prenatal care. So this shows an important opportunity to provide better care to people with disabilities in pregnancy. Now, there are also a number of gaps in the literature. Most previous studies have focused on particular disability groups, so one group within the larger population of people with disabilities. So, for example, those with physical disabilities. And this really leaves out an important cross-disability perspective, which is important for informing the diverse types of healthcare approaches that might be needed. Most studies have also been descriptive, which means that although they've identified disparities between people with and without disabilities, they've not really accounted for the possible reasons for these disparities, such as those underlying social and health determinants that I mentioned previously. And finally, until now, there's been really no large population-based studies in Canada where income is not a barrier to care. So our healthcare system affords us a really important opportunity to be able to examine this issue, because unlike the United States, income should not be the reason why people are experiencing barriers to care. So that leads me to the first part of this research, which was a population-based study. And our overall goal was to compare the maternal and neonatal health outcomes of women with physical, sensory, and intellectual and developmental disabilities compared to those without disabilities. Now, in Ontario, we have a really unique opportunity to look at this topic, because in our healthcare system, we have health administrative data that are linkable at the individual level for every single Ontario resident. That's available through ICS, which is a nonprofit research organization that holds our health administrative data. So what we're able to do is we're able to link information on physician visits, hospital admissions, emergency department visits, and sociodemographic data using a unique encoded identifier that protects individuals' identities, But what we're able to do is to use that information to be able to create cohorts of people that we're able to follow over time since 1988, when these databases were first created, until present day. And we're also able to link information on mothers and their children as long as children were born in Ontario. And so this gives us a really unique opportunity to be able to study pregnancy in people with disabilities at a population level. Now, one of the challenges of doing this work is actually being able to identify disability within these health administrative data sets. In Ontario and in Canada, we don't actually collect information on disability from the perspective of the individual with disabilities in health administrative data. So unfortunately, that does mean that we are restricted to using information on diagnoses as a proxy for disability. And those of you who work in this area will know that this limits us to a medical model of disability rather than a social model, which is not ideal, but currently this is the only way of doing this work because there's no other source of information on both disability and pregnancy available at the population level in Canada. But what we're able to do is identify diagnoses that are permanent and are related to restrictions to activities as well as participation. That gives us a proxy of physical, sensory, and intellectual or developmental disabilities. And we're able to identify those based on their record in physician visits, hospitalizations, and emergency department visits anytime between 1988 and when the pregnancy was conceived. And so this gives us a pretty good idea of a population of 15 to 49-year-olds with physical, sensory, and intellectual or developmental disabilities, as well as those with more than one of these disabilities compared to those without disabilities in Ontario. We looked at a number of maternal and neonatal outcomes, which are those tracked by the Canadian Perinatal Surveillance System. These include severe maternal morbidity, which is an indicator of life-threatening complications, maternal mortality, postpartum acute care, which is an indicator of lack of access to preventive healthcare in the postpartum period. We're also able to look at a number of neonatal outcomes, including preterm birth, small for gestational age, which is basically being born low birth weight for one's gestational age, neonatal complications in the form of neonatal morbidity and mortality, as well as congenital anomalies. And these data are derived from linked maternal newborn hospital records. So I'm just going to give an overview of the findings. I won't get too much into the analysis approach, but again, if anyone has questions, I'm happy to answer them. But just to give you a sense of the population that we were looking at, we were able to identify a cohort of about 200,000 women with disabilities with a baby born between 2003 and 2019. The most common disabilities that we see in our cohort are physical disabilities, including musculoskeletal disorders like rheumatoid arthritis, neurological disorders like multiple sclerosis, permanent injuries like spinal cord injuries, congenital anomalies like spina bifida. We were also able to identify individuals with hearing and vision loss, those with intellectual or developmental disabilities and autism. And then the final grouping on this slide is a breakdown of how often those disabilities co-occurred. So for example, if someone had a physical and a sensory disability, so we were able to capture that overlap as well. So taking a look at our study population, when the population entered pregnancy, so in the year before pregnancy, we observed important disparities on many markers of what we call preconception health, or one's health entering pregnancy. Not surprisingly, based on what we know from the literature, there were notable disparities in neighborhood income quintiles, so people with disabilities were more likely to live in poorer neighborhoods. They were also more likely to have higher rates of chronic illness like diabetes and hypertension, mental illness. They were more likely to be taking medications that could have an impact on the pregnancy, and they were more likely to have experienced a documented assault. Now, disparities were observed across all the disability groups that we looked at, but notably women with intellectual and developmental disabilities on all markers tended to experience the largest inequities. We were also able to look at access to care, and this is a master's project that came out of this work. So this is an indicator of adequacy of prenatal care, and basically as the colors get darker, that means more intensive prenatal care. And so what we really see is that women with intellectual and developmental disabilities in particular were more likely than their peers to receive no prenatal care or to receive inadequate prenatal care, which would be prenatal care that started too late or was too infrequent. So at a population level, an important indicator that there are major access issues in this population. We see this play out in the data when we look at pregnancy outcomes. So these are results from multivariable regression analyses looking at the association between disability and a number of different outcomes, starting with severe maternal morbidity and mortality. And what you'll see in these tables is an indicator of the absolute rates of the outcome across the groups that we looked at, the unadjusted risk of each disability group relative to those without disabilities, and the adjusted risk once we take into account those preconception health disparities that I mentioned on the previous slide, as well as social disparities that were mentioned as well. So it's trying to look at whether those risks could be explained by baseline disparities that we know are there. So what we see in this slide here is that all disability groups were more likely than those without disabilities to experience severe maternal morbidity or mortality, and this remains significant even after accounting for some of the social and health disparities that we were able to address. And the most common diagnoses explaining severe maternal morbidity were things like preeclampsia, which is a major complication related to kidney function and hypertension, major infections, a major postpartum bleeding, and ICU admission. So all of these are life-threatening complications. We broke this down by whether these complications happened in pregnancy, in the first 6 weeks postpartum, or thereafter. And what we see is that the risks are consistent in pregnancy in the first 6 weeks and up to the end of the first year postpartum. And this is a really important finding because typically in Ontario, people only receive obstetric related care until 6 weeks postpartum. And what we see is that risks continue beyond that point when people are typically no longer receiving obstetric care. We see this play out in postpartum acute care as well. And again, this is an indicator. You know, we expect to see emergency department visits and hospitalizations when people are not getting the preventive care they should be getting in an outpatient setting with their family physician or obstetrician. And we know in Ontario that emergency department visits in the postpartum period are quite high, even in the general population. But what we see here is that they are even higher in people with disabilities across the different disability groups, and even after accounting for some of those baseline social and health disparities. Likewise, hospital admissions, although somewhat lower in an absolute sense, again, we see people with disabilities being more than twice as likely in some groups to experience postpartum hospital admissions. We broke this down further according to timing as well as diagnosis. So this is a bit of a busy slide, but essentially what you see is that both in the immediate postpartum period and then leading up to that 6-week obstetric visit and then to the end of the first year postpartum, we see elevated risks in people with disabilities compared to those without for obstetric reasons, for psychiatric reasons, and for other medical reasons as well. So pretty consistent patterns regardless of timing or type of visit. Same sorts of patterns in those related to postpartum hospital admissions. And I'll just point out as well that for both this slide and for the previous one, really what we're seeing is elevated risk across disability groups, but the greatest risks in those with intellectual and developmental disabilities as well as multiple disabilities. We see similar sorts of patterns when we start looking at neonatal outcomes. And again, these are outcomes that could be prevented through better prenatal care. The differences between people with and without disabilities are not as large, but they are significant. And so we do see higher rates of preterm birth and small for gestational age in babies born to women with disabilities compared to those without disabilities. And similarly, we see disparities related to neonatal morbidity as well as mortality, although thankfully mortality is rare in newborns in Ontario, and so some of those findings are non-significant. So a couple of nuances to this. We tried to really kind of understand some of the characteristics related to the disability group. And interestingly, what we saw is that if a woman was diagnosed with a disability in childhood compared to later, the risks of maternal and newborn complications were even greater. And I think this really speaks to sort of long-standing barriers in access to healthcare for people who grew up with a disability compared to those who, for example, might have developed multiple sclerosis or something like that later in life. So, you know, the disparities exist regardless, but they were greater in people who had a disability for most of their life. Similarly, we saw risks being greater in individuals who had ongoing healthcare encounters for their disability compared to those with only, you know, more distal healthcare encounters, suggesting those who had a more significant disability experienced greater disparities. It's important to acknowledge that many of these analyses are at a very, very high level, and we know that there's a lot of heterogeneity in the experiences and the, you know, circumstances of people with disabilities within those groups. So we did break the groups down further by different types of disabilities related to musculoskeletal disorders, neurological disorders, permanent injuries, and congenital anomalies like spina bifida. We also looked in more detail at people with sensory disabilities, including deaf women and those with vision loss. And essentially, we see consistently elevated risks, even in those more specifically defined subgroups. So I hope that those data provide kind of an overall view of, you know, at a population level, what sorts of inequities are we seeing? But we can't stop the conversation there. Then we really need to understand why these disparities are happening and what we can do about it. And I think that's where qualitative research really becomes important, because our population-based data don't allow us to ask those why and how questions, but qualitative studies really do. And so in the second half of this presentation, I'm going to focus on the other component of this study, which was a large-scale qualitative study. And there were several people involved in leading this, including my postdoctoral fellow, Leslie Tarazoff. So I think these data really provide an important insight on why we might be seeing the disparities that we see. So the overall objective of this component of the study was to explore the pregnancy and postpartum healthcare experiences of people with physical, sensory, and intellectual and developmental disabilities. And this was a large undertaking. We worked with over 100 organizations that serve people with disabilities, as well as advertising on social media, in order to identify and interview people who had had a pregnancy in the last 5 years living in Ontario. We also interviewed health and social service providers and decision makers in government and healthcare organizations to try to understand, you know, what people's experiences are like and what the real barriers in the system are. And in the end, there were, I believe, 62 interviews that were conducted, with 31 interviews with people with disabilities and 31 with health and social services providers. And this analysis is ongoing using thematic content analysis, but I'll provide some information on the emergent themes that we're seeing. So starting with the people with disabilities that we interviewed, there were major themes related to negative provider attitudes, disability-related medical trauma, gaps in care and isolation, and feeling a need to have to prove oneself as a parent with a disability. So I'm going to provide a couple of quotes related to each of those themes. So first, starting with negative provider attitudes, this was something that was pervasive across the entire sample of people with disabilities. Everyone had had a negative experience with a provider, and I think this one in particular is quite striking. This individual said, "I met him, the doctor, for the first time when I went in to confirm the pregnancy. I went in and I said to him, he was like, 'What brings you here?' 'Oh, I just found out that I'm pregnant.' And he looked down at my wheelchair for a second and he looked at me and he said, 'Are you here to get an abortion?' And I was absolutely stunned. My mouth fell open. I didn't know what to say. I guess he looked at my wheelchair and thought, 'You don't want it, I guess.' It was like, 'No, we've been trying for a year and we're really excited.' And that was a really weird and terrible kind of experience." And I think this is an important one to reflect on. This was this person's first interaction related to their obstetric care, and this is not an isolated story. It's something that we heard over and over and over again. Throughout people's pregnancies, there's a lot of reflection on how prior disability-related medical trauma impacted how they experienced prenatal care and some of the more, I guess, invasive aspects of prenatal and labor and delivery care. So one individual who had multiple sclerosis noted, when I first got diagnosed with MS, one of the first tests they do is a spinal tap, which is very much like an epidural. So an epidural is pain relief that people often receive during labor and delivery. So when this person was ready to go into labor, she said, I was gowned and prepped and I didn't have the epidural. So I did like 2 procedures to turn the fetus from breech position without an anesthetic. And my doctor looked at me and said, oh, I didn't know what to do with that concern. So she had a lot of trauma and fear about the epidural related to her prior experience. It meant that she didn't get the pain relief that she needed. There's a lot of reflection among our sample as well on gaps in care, especially in the postpartum period. So one individual reflected saying there were no resources. I just had the baby and we're done with you. You know, when you're a quote high risk pregnancy, it's a double-edged sword. Okay, great. You have the obstetrician looking after you, but after you deliver the baby, nothing happens. You're done. If I'm high risk, wouldn't it still be high risk 6 weeks after the postpartum? And I think this quote, if you remember the slides I showed in the postpartum period from the population-based data showing the extended risks across the postpartum period, I think that really speaks to, you know, a real drop-off in care that has real consequences. Likewise, a lot of people talked about a lack of broader supports that they would have appreciated. So one individual said it would have been helpful to have some sort of mental health support or just help from other disabled people, because I remember feeling very isolated and all the people I was seeing, they didn't get it. I was also very wary of appearing to struggle too much. So if there was a way to have a safe person to share what you're struggling with, maybe someone who actually sat you down and said, I know this is an issue with disability, I'm aware of it. These are the only instances that I would call CAS. I would have had more trust if I knew the person was aware of that or was disabled themselves. And I think this really speaks to the distrust that people rightly experience, knowing that their healthcare provider could call Children's Aid Services, and often those calls are made with, you know, no evidence, but simply because a parent has a disability. And so there's a lot of fear in seeking support for fear of Children's Aid Society getting involved. And that really relates to this last quote as well, this sense of having to prove oneself or act like you're fine just because of the assumptions that are made related to disability. So one mother noted, as a disabled mom, I felt I had to make it seem like I was doing better than any quote normal mom because I was afraid if people thought I couldn't do it, then they would assume that it was a mistake for me to have a kid. I didn't reach out to supports because I was trying to hide. That was really hard. Even if people told me, yes, it's really hard, I felt I had to still prove that I was doing okay. And this is something that we heard consistently. And we also heard it especially in individuals who had disabilities that weren't immediately visible. A lot of people did not feel comfortable disclosing their disability to their healthcare provider because they were worried that that would have a negative impact on their care and their interactions with the provider. So moving now to the service provider and decision maker side, the main themes that emerged there was an acknowledgement of the lack of training that healthcare providers and social service providers receive related to disability and reproductive health. There was also an acknowledgement of the lack of time and resources that many providers have, even if they want to deliver equitable care, the system is not built to support them in doing so. And then a lot of providers also acknowledged the prevalence of negative attitudes among their colleagues towards disability and pregnancy. So a couple of quotes to illustrate those. Related to a lack of training, one provider noted, a lot of it is self-taught. The electronic learning module that I did online, but there's no training. So I do formal training for others, and they whispered, I just didn't do training myself. So we heard this a lot, that people who had expertise related to disability and pregnancy, it was because of a personal interest, not because of something they received formal training to do. And they really had to seek out the resources themselves and then act as a champion for other providers. So illustrating this, another provider said, we got no exposure at all in medical school. It really wasn't discussed. So most of them had never even thought about disability in the context of reproductive health, or even disability at all. There was also a real lack of resources for providers to be able to give good care. One provider noted, because there's a lack of financial or remuneration, some people will choose not to want to work with this population. Maybe it takes a little bit more time and a little bit more work and a little bit more creativity. And we really see that in the way that primary care as well as obstetric care are set up. We tend to be restricted to, 10 or 15-minute office visits, and providers aren't compensated for doing anything above and beyond that in terms of the amount of time spent or any sort of coordination work or communication with other providers. So the system is not set up to incentivize them to provide comprehensive, flexible care. And then finally, related to that negative attitude piece, one provider noted, and then I think some people choose not to work with people with disabilities because there's ignorance around who they are and how they can participate. So I think that really reflects a lot of the experiences that we heard from people with disabilities themselves. So I'd like to end on a few thoughts related to recommendations for improved clinical care for people with disabilities. There's a long way to go, I think, in this area of research, but certainly from the work that we've done and that others are doing in this area, in the States especially, we're starting to see this sort of convergence of ideas and a real drive towards some systematic recommendations. So that gives me some hope and excitement that something more systematic will come from this work soon. So I just want to provide a brief summary of the findings just to kind of bring it all together. So again, what we see from our population-based data is these higher rates of maternal and neonatal complications in women with disabilities compared to those without disabilities, really driven by clear inequities in preconception, social, and health characteristics. But if you'll recall from those relative risks that I presented, those inequities did not completely explain differences in risk. And that really leads us to this question of, what else could be going on? And that really points us to these broader structural issues related to the quality and quantity of prenatal and postpartum care that people with disabilities are experiencing. And so, again, we see that really reflected in our qualitative data, these significant barriers to optimal prenatal and postpartum health care. So what can we do about this? But first, I do want to acknowledge some of the limitations that impact, what we can take from this work. As I mentioned with our administrative data, we really are limited in our ability to identify disability to a medical model of disability. Unfortunately, in Canada, we don't collect information on disability from a social model in our healthcare records. There are a number of Statistics Canada surveys that include questions about disability, but those surveys don't tend to also include questions about pregnancy. Likewise, we have 1 or 2 Statistics Canada surveys on pregnancy experiences among Canadians. Those surveys do not contain a single question about disability. And so if we want to study this issue from a population-based perspective, we really have no opportunities to do so in Canada other than administrative data. And so I think this is a real call in some ways for making sure that disability data is included in places where we're studying pregnancy so that this is overcome. But in the meantime, our health administrative data in Ontario do give us the opportunity to at least have an overall view of the inequities that we're seeing as a means of pushing this information forward. However, population-based data are limited in other ways as well. We're limited in certain contextual factors. We also have no information on other forms of discrimination that people experience. So for example, systemic racism. And we know that people with disabilities are overrepresented in racialized populations. And so there is a real need to study this issue from an intersectional point of view, but we need the data to be there to do that. For the qualitative study, a number of limitations to consider as well. We interviewed 31 people with disabilities. Most of those individuals had physical disabilities or intellectual disabilities. We also interviewed a number of people who were deaf, but we only interviewed, I think, 3 or 4 people with vision loss. And so, you know, as we move this work forward, we're really hoping to hear more from those groups that weren't so well represented in the sample. Likewise, although we had 31 interviews with service providers and decision makers who provided some really rich data, those people that we interviewed tended to already be invested in the topic. And so, you know, their answers to our questions reflect answers of people who already care. And I think we really need to also hear from the service providers who are not invested in this topic and who maybe have never thought about disability in the context of pregnancy. So that's an important area for future investigation as well. So moving now to some recommendations. I think one of the first pieces that we've started to think about is this idea of thinking about health across the life course for people with disabilities. Many people with disabilities told us that, you know, as teenagers and young adults, their providers really never talked to them about reproductive care. They never talked to them about their reproductive life plans or whether they wanted to have a baby someday. Their care was really solely focused on their disability and other kind of traditional medical needs related to things like diabetes and hypertension, no kind of support related to being a broader person and a woman or a female with, you know, plans to maybe have babies someday. And so I think there's a need to shift approaches to reproductive health care for people with disabilities, to think about care from a life course perspective, to think about preconception care, including having discussions with people with disabilities from their healthcare providers about their plans for reproduction, if that's something that they desire, and thinking about health promotion in that context, as well as addressing social determinants of health well before a pregnancy. There's a need for elevated support throughout pregnancy and the first year postpartum, as well as a need for a focus on interconception care as well. And this is something that's becoming more common to look at in the literature, this idea that once a person has experienced one pregnancy, we know that most people in Canada, statistically at least, will go on to have a second pregnancy. And so that period of time between the 2 pregnancies is a real opportunity to sort of catch people while they're more in touch with the healthcare system and provide them with better supports going into the second pregnancy. But a really big take home from this work, I think, is the importance of remembering the social and structural determinants of health. So considering the complex ways in which the social determinants of health impact people with disabilities. Again, you know, you'll recall these images from one of the earlier slides I showed you, showing that people with disabilities experience inequities in all social determinants of health across their life course. And so, you know, in some ways, this research is just reflecting broader issues that need to be tackled in our healthcare system and in our society, because we know that these social factors are also barriers to healthcare, to perinatal health and perinatal mental health as well. Thinking about the structure of care, there's a real need for services and supports and resources to be adapted to the physical, sensory, as well as learning needs of diverse populations, taking into account the accommodation needs of people with disabilities. And one of the questions we asked in our interviews with people with disabilities is, what recommendations would you make for healthcare providers to give better support? And many of them said, just ask me what works for me, because often if providers did provide support, they provided it in the way that they thought was most helpful. But people with disabilities are experts in their own care, and so oftentimes they really would have appreciated being consulted and being given the latitude to be able to, indicate what worked for them, and to also make recommendations about the other services that they had involved and wanted to be involved during their pregnancy. I think there's also a real need to work proactively to make sure that these supports are in place before the pregnancy or early in pregnancy. We heard from a lot of people that it was very much a reactionary approach to their care, that everyone would sort of jump to attention when something went wrong. And so I think there needs to be more of a preventive and a health promotion perspective, as opposed to a medicalization approach that only reacts to complications. And all of this really requires that healthcare delivery approaches be more flexible, and of course this requires that our healthcare system provide remuneration approaches that allow physicians to spend more time with patients. And I think underlying all of this is a real need for better training for healthcare providers. There's some really interesting work from the States noting that people with disabilities make up the largest so-called minority population, but few health and social service providers actually receive any disability training at all during their medical training. And that's especially obstetricians, but other types of healthcare providers as well. And so I think there's a real need to ensure that all clinical students, whether that's medical students, nurses, nurse practitioners, social workers, receive disability training. And there's some great resources in the United States that are being developed. I've included a link on the slide that would be a great example for Canadian medical schools and other training facilities as well. So I wanted to finish off by mentioning a couple of resources and I guess movements forward that we've seen as a result of this work. I think in her introduction, Irina mentioned the primary care guidelines for adults with intellectual and developmental disabilities from the Canadian College of Family Physicians. Based on some of this early work, these guidelines were updated in 2018 to include for the first time recommendations around providing prenatal care to women with intellectual and developmental disabilities. It's a guideline that's about primary care more broadly, so we didn't receive too much space, but there's 3 guidelines around pregnancy care, which was really exciting because reproduction and pregnancy was something that historically had not even been covered as a topic in these guidelines. So to see it there is a huge movement forward. We also had the opportunity to work with Health Nexus, which is Ontario's health promotion organization, to create a childbirth preparation support tool for individuals with developmental and other neurological disabilities that allows healthcare providers to work through a worksheet with them and identify the broader supports that might be helpful to them during pregnancy. And finally, just this last year, the Society of Obstetricians and Gynecologists of Canada released the first pregnancy care guidelines for people with physical disabilities, which references some of our work around preconception health disparities in this population. So I think there's a lot to be hopeful about in terms of a shift in the medical community towards providing more attention to this topic, but still lots of work to be done. And I'll end there by acknowledging our funding source as well as the source of data for the population-based study. And I think we have some time for questions. Thank you.
Thank you so much, Professor Brown. What a fascinating but equally sobering presentation. I'm going to look for any hands raised who want to ask questions. And as I wait for a hand to go up, maybe I can start with a question. And you did mention this a little bit towards the end of your talk. You looked at the intersection among different disabilities. Did you or did you not have access to data that enabled you to look at the intersection between people with disabilities and other equity deserving groups, such as those from the Black and Indigenous communities, or was that outside the scope of your study?
That's a great question. So in Ontario, we do not collect information on race and ethnicity in our health records, so we're unable to look at the intersection between, experiences of ableism and experiences of racism, and that's a major issue. I sort of suspect that may change because of COVID, because there's been a big push towards including equity-related data in the health record. So I hope that that will change. So, but we were unable to do that in our population-based data. We do have quite a nice diverse sample in our qualitative study. So one of the plans for one of the papers is to try to tease apart some of the experiences at the intersection of disability and experiences of racism, but we have not done that yet. Yeah, that's an important area for future work for sure.
Thank you, Hilary. I think what you've done is made it really clear to me why the issue of data was raised so often during the health symposium, because I didn't realize that this data isn't available publicly or to researchers. So thank you for clarifying that. We have a question from Kate and then Notisha. So Kate Steinman.
Hi. Yeah, thank you, Hilary, for such an interesting talk, especially your comments on negative attitudes, systemic bias, and disability-related medical trauma. It was also interesting what you were talking about, your recommendations for medical training. But yeah, so my question is something that I assume was outside the scope, but still that you might know about. And it's just about the pandemic. And so recognizing that people with disabilities have been disproportionately affected by COVID-19 in general. Is any information available or data available on the association between access to vaccination, for example, for people with disabilities and maternal or neonatal outcomes? And then another aspect of that would be, has access to prenatal care during the pandemic been significantly restricted for people with disabilities?
That's a great question. Yeah, we certainly hear anecdotally that that has been an issue, that these disparities that we see prior to the pandemic have been exacerbated. And that's actually something that we're studying right now. We just received a CHR grant to look at the impact of COVID on reproductive health care for people with disabilities. It's a partnership with Dawn Canada, which is Canada's national feminist disability organization. So we'll actually be launching a national survey and interviews hopefully later this month to look at that. But yes, I suspect that we will unfortunately see a negative impact of the pandemic on these outcomes. Yeah.
Thank you.
Thanks, Kate, for your question. Natisha?
Thank you so much, Hilary. It was an incredible presentation, incredibly important research and data. And I'm glad you flagged some of the challenges of being able to look at racialized populations with our current health data systems. It's hugely glaring, especially now with COVID. But my question is about even my own work with Black women in particular. In clinics, what you'll notice is late to care or very limited prenatal care, and it's very common. And so some of the work from an advocacy perspective is to deal with the barriers that are creating that scenario. And then I saw it show up again in your data with women with disabilities, right? The high percentage of those that didn't have prenatal care. So I'm wondering, we're able to look at the pregnancy and prenatal, postnatal outcomes of that particular group of people, right? People who had very limited prenatal care, but also what some of their experiences are with healthcare providers when they show up at that point. Like we can report high rates of calls to CAS and all kinds of other things, as opposed to the interventions that are required to deal with the facts and the reasons why people weren't able to access prenatal care. And my very long convoluted question, I just noted so many parallels in your data when I look at the experiences of Black women. I can only imagine how it will get amplified if we intersect disability with that population. But the outcomes I'm interested in for women who don't have access to prenatal care, just so that we can get prepared as service providers to address the issues.
Yeah, absolutely. Excellent point and excellent question. I have a master's student right now actually looking at that. So she did her first paper identifying the disparities in access to prenatal care disability compared to people without disabilities. And now we're looking at the impacts on the outcomes of that. And yeah, it's exactly that, you know, first you experience the barrier accessing the care, but then you also have all the disparities you know, along with the disability, driving this increased risk for pregnancy complications, and so that lack of care exacerbates the risk of pregnancy complications. And we see that most among people with intellectual and developmental disabilities, and I think it really speaks to the very real and justified fear of interacting with the healthcare system, because we hear this language of being red flagged. That's how the mothers themselves described it, that as soon as they sought prenatal care, they were red flagged, and CAS got involved before any sort of evidence, you know, without any evidence that they needed to be involved. And so of course you wouldn't seek care if you knew that that was going to have a negative impact on your life and your ability to, you know, parent your baby. So yeah, lots of parallels for sure.
Thanks, Natisha. I mean, there's so many questions I would love to ask, and there's only a couple minutes left. So, you know, including with the data that of the missing data, so to speak, those who are not even captured by the system, who fall through the cracks, and related to that, the barriers and biases of some of the healthcare professionals. So this will lead to my final question that I think we can have in the time remaining. As we work towards creating a School of Medicine at UT Scarborough, how would you take the lessons learned from your study to guide the design of training for healthcare providers, such as family doctors, specialist doctors, nurses, etc.?
That's a really great question. And I think certainly from an academic point of view, my first answer would be they need to be trained about disability. They need to interact with people with disabilities throughout their training and hear their stories. So disability needs to be part of the medical school curriculum. It is not currently in any sort of meaningful way. Somebody might have, you know, a 2 or 3 hour module in their entire training. That's inadequate considering that 1 in 5 people in our population have a disability. But more than that, I would say that training needs to be driven by the desires and needs and content identified by people with disabilities and disability advocacy organizations, because they are best equipped to convey what that training needs to include. So it can't be, you know, a top-down medical school driven curriculum. It needs to be a community driven curriculum. And we saw that over and over again in our interviews with people with disabilities, that they know what works for them and they know their needs. And so I think it really needs to be something that's driven, educated by people with disabilities.
Well, I hope that in the very near future, we'll be in a position to start having those community consultations on design principles for what a School of Medicine would look like that is really integrated with the community. Thank you so much, Hilary, for a fabulous discussion and presentation. And now I will turn it back to Joshua.
Thank you, Professor. Thank you, Professor Brown. I just wanted to thank everyone once again for attending. Professor Hilary Brown's website, our UTSC Research YouTube channel, which this lecture will be uploaded at some point, probably later today, and uploaded to this channel. So if you want to watch it again, that's the place to find it. The link to the video, as well as a paper of Professor Brown's, will be sent out to everybody who registered for this event. And there's also our website here. And then just a reminder that our next OVPRI Research Excellence lecture series will be Wednesday, April 6th, with Professor Stefanos Henritakis. And yeah, thanks once again for showing up today.
Thanks, everyone.
Thank you.